So much, Elizabeth Minnick, West Virginia Project Echo.
Awesome. Thank you all so much. What a great group we have here. We don't have a didactic today, but Miss Jen Boyd has prepared a case for us. So Jen, I'll pull up your case for you. Just let me know when to scroll up or down. Thank you.
Okay, thanks. The patient that I'm using for this case, which is actually sort of a general topic, a general question, but the patient that I'm using to demonstrate is a 32-year-old Caucasian female who has Medicaid insurance. And my question is, in general, is about untruthfulness, lying, deceit. Actually, Mitra, can you scroll down to the HPI first so I can talk about her? So she started general assessment. So this lady started in our program in December of 2020. At that time, her drugs of choice were heroin and meth, and she uses them by smoking. Her drug use goes back a long way. She started with marijuana at age 13. And you can see there the list of things that she has used, some of those up until quite recently. She relapses frequently on meth. She hasn't gone more than 21 days sober since she started our program. Her social situation is she lives sometimes with her mom, sometimes with her boyfriend who has substance use disorder and is not in treatment. Actually his mom, they live in her household, is also in our program and has been doing fairly well. I think she might be coming on 1 year of sobriety, something like that. I think she has 2 children and they live with her mom. Every so often she talks about living with her mom being in boot camp. So supposedly her mom is strict, but she's not always there. She works as a housekeeper or a house cleaner for different places or people. And at some point she was in rehab for a year. I just found that out recently and I think she said she was sober for two years after that. Amy may remember that. I'm going to put in my headphones here and then we can scroll up to my questions again, Mitra. Hear me okay?
Yes, we can.
Okay. So my question about her has to do with lying, basically, to be blunt. She regularly fibs to us, and sometimes it's about relapses, and sometimes it's about the reason for her relapses, and it's about her living situation, her work situation. But pretty much every week she tells a really pretty amazing story. Sometimes they're more amazing than others. We use her urine drug screens and confirmations to verify when she's had relapses, and we use the appropriate interventions. We have talked about as a team and chosen not to confront her about other things that she lies about or the fact that she is untruthful about facts in her life. And our thinking on that was just to not get into a, like, we checked on this and you're lying, kind of a super confrontational thing. The most amazing one she told us one day that her grandmother had died and that was why she had relapsed. And I asked her who her grandmother was and I thought I recognized the name. And so I looked it up. Her grandmother died 6 years ago. And so I was like, wow, that's pretty impressive. So anyway, it does affect the group. Patients see her lying and they have started remarking to us about it. And that's mostly about relapses. So we do talk in our program about truthfulness, and we talk about it at induction. We talk about it in a medical group as a whole in general, and we talk about it in our behavioral health groups. I got really interested in talking to you all about this because recently we've been collaborating with the drug court program here in Fayette County, which has been an interesting experience. And we had 3 males coming through the drug court program who were in our program. and they didn't tell the truth about various things, relapses. We figured out that they were forging meetings, and we confronted them ultimately about their meetings, and we talked to them about relapses. There was a little bit of a delay in when the drug court team found out that they had been lying about these things, and the judge last week sent them to jail for a week for lying. And that's what he said. He said, we just don't tolerate lying here. And so I found that really interesting. So just to summarize, I think that deception, it seems that deception is part of what happens when you have substance use disorder to get along. And yet in the program, obviously it's not great. And so I'm curious to know how and when people address that with individual patients, just as a general topic of conversation.
Thank you so much, Jennifer. What an interesting case. Did anyone have any clarifying questions or comments that they wanted to ask Jen? Feel free to unmute or chat in.
So Jen, this is David Baltiera. What do you guys do when a patient's dishonest about their drug screens?
We, let's see, obviously first we verify their drug screen with a confirmation, and sometimes we let them know the results of the screen and let them know that we're sending it for confirmation. We don't necessarily always let them know. Sometimes we wait for the confirmation to come back. And then if the confirmation verifies, we let them know if we haven't let them know yet, and we reset their days.
Right, and so I mean, that's what I was getting at. We count that as a positive because part of their treatment plan is them being honest, and it's not, it's not my honesty, it's them, and it does disrupt your group. I've actually had patients, we require them to bring us proof of deaths of family members, which sounds really horrible, but what you're telling is not unusual. I kind of have a joke, you can only have, 2 mothers die, and then, but even that, it really is kind of, and so, I think part of the psychology is our patients are used to lying. That's kind of, are you using drugs by the police? No, I'm not. No, I'm not. And so it takes a while for them to become honest. So I don't expect that immediately. But when somebody's been in the program for a while, that's part of their treatment. And I think by not addressing it, it's, there's something underlying that. And it's about their being honest with their treatment. And so I think addressing it, confronting them, say, look, we're starting to require obituary testing, or, got to send me the obituary link. And we've done that. It feels really strange at first to say, I don't believe you that your mother died or grandfather's in the hospital. We've had patient had COVID how many times this year? COVID's a great excuse. And so we've actually started requiring them send us the COVID tests, all those things. And it's not, about getting them in trouble or, putting them in jail. It's about, if they don't address their dishonesty, they can't really move forward because they're not confronting their addiction. And so that's how we've addressed it. And we have, been, hearsay is tough. Somebody says, oh, so-and-so is using, or, they're dealing. That's a tough one. But if we have objective evidence, like, grandma didn't die and you're using that as an excuse, well, we need to address that individually, maybe not in group, but we do bring them in for individuals for that.
That was my other question, is what's the follow-up on that? And I guess sometimes there would be a programmatic follow-up depending on what they're trying to get out of. I mean, at one point, this woman who I presented was trying to get out of coming daily for IMAT because of, I think, missed meetings, or I can't remember now what, it was quite a while ago, but at any rate, so sticking with whatever consequence they were trying to get out of seems like one thing. But then that was interesting what you said about addressing it individually as a part of the treatment.
Dr. Hirschler and Dr. Houston, I noticed you both unmuted a little bit earlier.
Yeah, I was just going to say, I use a very matter-of-fact approach to dishonesty, and it's kind of normal behavior for somebody who's in the throes of addiction, and just to matter-of-factly say, I'm kind of like Columbo about it. I say, you said this, and it doesn't add up, and so you got to be honest with us. I'm just very matter-of-fact about kind of what makes sense, and this doesn't make sense, and kind of lay it out there.
I think it's easier. It's more comfortable just having done psych for a while now. It's more comfortable not to call people out or say what's going on. But the more avoidance, I think it's just going to reinforce the behavior that she's just going to keep lying and lying and lying until someone actually calls her out. It's never going to get better. So as uncomfortable as it can be, it's not going to change until you do. So, probably individually would be better, but sometimes you do have to do that in a group. If someone's like abusing the system so much, sometimes it does call that, call to question that you need to call it out, because if she's doing, there's probably some other people. And if they see she can lie every time and there's no repercussions, she doesn't even get called out in group. It's just going to encourage other people to lie. So it's kind of a disease, I would say, that needs to be rooted out. So.
I'd like to just add, we had a patient that we had in treatment for a long time, and she chronically lied about all kinds of things. I mean, she always came to her appointments. She always made her appointments, but she would tell us off the wall stories about why she would relapse or something happened with her husband or these things. But we would question her story enough and point out all of the holes in her story so that she would have to keep going. And eventually, as we continued to do that with her, her lies minimized. She actually is doing really well in the program now. And when she starts that behavior again, it's kind of like you're going down that road. That road that's not real good. You need to back up, and she'll keep with that lie. But the next time she comes in, she's usually back on track. But it's such a way of life for many of them that's how they've lived. They've had to tell lies. They've had to get their fix or their drug or whatever. That's just how and it takes them a long time to get out of that behavior and those thought processes.
I think part of our hesitation, it's none of us is afraid of confronting in a Columbo-like way. I think I could be a good Columbo, but I think it's tiresome to try to, it's just like, because some of them are so, some of the lies are so difficult to pin down. However, some of them are not. And so all the feedback is really helpful.
The mantra that I usually give people starting out COAT is I tell them, as long as you're honest and you show up, you'll do fine. Because if you're honest, even if you're struggling, we can work with that. If you're dishonest, it's hard to kind of move along. And of course, if you're not showing up, then all bets are off. But really, I think if you break down COAT fundamentally, just honesty and showing up, you do those two things and you'll do fine. So.
And, different things motivate lies. Sometimes it's about protection. Sometimes it's about getting your needs met. Sometimes it's about not being punished. And as someone, as Heather was talking about, it's really also a learned behavior. I mean, when you talk with patients who have longer term recovery, they'll say, I lied when I didn't even need to lie. I don't even know why I was lying. It was so automatic to lie that it was almost like a new behavior they had to learn to be honest. Now, other times people are intentionally lying to get out of something or to avoid a consequence. And it's probably some combination of both for her, because you said sometimes it's very obvious and other times it's hard to figure out. So to convey the compassion is sometimes a little bit easier to do one-on-one when you are, just saying, I really want to understand how to help you better, and we can't help you when you lie to us. It just makes it so we don't understand what's happening, and so we're not going to be able to give you the best treatment that we can, and we really want to give you good treatment. So what will help you be more honest? The other thing is shame and guilt. So especially working with pregnant women, tremendous shame and guilt around admitting relapse. And that's where I think the group can be so powerful, because they see other group members admitting, to a relapse, and, the world doesn't come crashing down around them, and we don't get stern and reprimand them. And so it helps to see other group members be able to walk through a difficult disclosure of truth also, and they can learn from that as well.
Dr. Morrison, was there a comment you wanted to make as well?
Yeah, I was curious, just sort of if there's been any changes regarding the prescribing practice at WVU regarding dishonesty on drug screens in the last year or so. The last time I checked on it, Douglas actually was still there, and he told me that if a person had been sober for a long time and they were honest about it, there would not even be an escalation of care. But if there were not honest, then there would be an escalation of care. Is that still pretty much what's happening?
Yes. So there's, the consequence to being honest is you lose your days, and it's really hard to be honest, but the consequence to lying and then it being found that you were not honest is typically a higher level of care.
Laura, I was interested in what you were saying about kind of the tone for, the tone of the group with the pregnancy group about how you handle people relapsing. I wonder if you'd say more about what the tone is like, or how you make it a safe space to slip and still get some feedback, but not feel trapped or criticized, or whatever your space is with that.
I mean, there has to be some brave person to go first and be honest. I was actually talking to a young lady today who had been in the pregnancy group, and she's about to hit her year anniversary, which is super exciting. And she admitted, she's like, when I was in that weekly group and I was pregnant, and there was an individual admitting that she was relapsing on methamphetamines, I was judgmental of her. And then she talked about her process of reminding herself of when she was in her active addiction doing not very well, she would have done the same thing. And so cultivating sort of compassion for group members for one another, and that self-awareness is when we do start to get into a place of judgment, because it's not easy. I mean, even today for me, it's not easy to hear a pregnant woman talk about, relapsing when she has a baby that she's trying to nurture in her own body. And so it's not easy for anyone. It's not easy for people with substance use disorders to hear that either. So being aware of that judgment that may pop up involuntarily, and it's okay. The important thing is to have an awareness of it and then what you do with it. So we try and create that space of it being okay to share about relapses, and then how to facilitate support among group members. Now, sometimes are they just sort of saying words and they're experiencing the bias or the judgment? Yeah, but it's practice that you can experience the judgment and still be compassionate and kind.
I just want to add that actually studies have shown people who are facing legal consequences, a lot of times they tend to lie more. So in this kind of case, I think probably she's involved in drug court, and she has to face legal consequence of relapse. So in that, I believe that's probably the reason she lied a lot. So I think Laura's approach is great, and find the reason, kind of what's the reason behind her lying, and hopefully we can just intervene, and using the individual approach and group therapy, I guess, I guess the problem now is she's disrupting the whole group and changing the whole group is kind of talking about her lying, her behavior, and that's going to affect the whole group therapy. I think that cannot be tolerated.
So I agree, Dr. Zhang. One of the things is if it is disrupting group therapy, we've sometimes pulled somebody out of group for 1, 2, 3, 4 weeks for a while because of that until they can, make some progress. Because I think you're right. They're used to saying, no, I didn't do it. No, I didn't do it. No, I didn't do it. And that may give you some time to individualize some of our therapy. Plus, I find a lot of our patients miss group. They like being in group. It's their social support. It's their social structure. And so that motivates them to get back into group and kind of working through the same way we would work through a lapse or a relapse, tell me what was happening, what, led to that, what are some other things you could have done. The same way with the lying is saying, do you realize whenever we ask you something, you say, no, I didn't. And, and so kind of working through that through some cognitive techniques may be helpful. We've done that where we've had somebody, you can't be in group, but if you reach a certain point, you may return to group. Because I find most of our patients like group. It actually is a motivator for them. I don't know if other people feel the same way that their patients like group.
I saw Laura Lander and Dr. Berry nodding their head to that. So absolutely. Thank you, Dr. Baltiera. And thank you all so much. This has been a wonderful discussion. Jen, were there any other things you wanted to discuss about the case specifically?
No, that was really helpful. Thank you.
Any other comments, questions from the group? It can be unrelated to that case. We can just start another discussion.
So from my previous study, actually in our co-clinic, we have more reported positive urine results than positive testing results. So that has said something about this program. So basically patients, of course, we always ask patients first. A lot of times they report use, but then the urine drug screen came back like a negative. So we this is very important because if they're not truthful about they're using, how can we help them? So I guess this is our program works because we talk about this and we learn from each other and we find a way to help them not to lie. I think it's very important. I guess when Dr. Sullivan started this program, I guess the two things I asked Dr. Berry as well. I asked them basically what's important. I guess the two things we do not tolerate. One is lying and dishonesty. The second is diversion. I think that's the key of our program, I guess.
It's sometimes comical to see people are disappointed when they tell the truth and then their urine doesn't tell the truth. Like, dang, I could have lied. And they'll say it right there. They'll say, well, yeah, you could have, but you didn't. Good, you didn't.
Yeah, that's true too. But it's funny. So many times too, I've had patients who say, I know it wasn't going to show up, but I needed to tell you that we used. Right. I used too. So it always surprises me, but it's encouraging that, whatever's going on there, whatever's going on between the sessions we have, we're making a difference, or the rest of the group is making a difference in this person's heart and mind, that they really feel like, all right, it's important that I disclose this, even though I know it's probably not in my system now.
And the people who want to continue to screen to keep what they say, to keep me honest,
Yeah, that also brings up, I think that's a great place when your patients get to that point where they're telling you, even if their test is negative, because if they really want to use, there's enough drugs out there that we're not testing for that they could be using behind our backs. So there's stuff out there that, depending on what their drug of choice is, but there are other drugs out there now that we're not testing for regularly. And so we do rely on, for their own improvement, on them being honest.
And I see in the chat here, Dr. Morrison, thank you for that. He was just asking a patient recurrently uses, I believe, benzo with bupe, is there still a place where we stop prescribing as outpatient? So I'll just open that up to the group, or Dr. Morrison, if you wanted to expand on that.
I'll just say I've got a guy that's used benzos a lot for a long period of time, and then we did in the past, we suspend him, and then he would just come back 28 days later and then start using benzos again after getting back on bupe. And so I didn't know if I should keep doing this pattern where it doesn't seem to be improving his situation, but putting him at risk of eventually a serious consequence where he's out of the program. So historically, there was, 2 or 3 times, we would say, well, you have to go inpatient to get this taken care of. But I don't think that's how it probably is after COVID. I don't know. Maybe it still is that way.
So that's a tough one. I can't remember any time, unless some of the other providers in our program up here in Morgantown can remind me, where we've just had that case where somebody just continues to return to us on benzos, unwilling to come off. Can you guys remember, or ladies remember, a time like that?
I can think of a case of a female patient who chronically used benzodiazepines, and finally she was started on Effexor and had a pretty good anxiolytic effect from that, and was able to get off the benzos, and that persisted for over a year of dealing with escalating her treatment, and finally she agreed to get on Effexor, and it was very helpful, and she stopped using them.
Yeah, I can actually think of a similar patient. I don't know if we're having the same patient or if this is a trend. She was with us for 5 years, and she would consistently relapse on benzodiazepines. And we retained her, but she just, she just stayed in weekly group for 5. I mean, that's a long time to be in weekly group. She would make it to biweekly, and then she would come back down because she would relapse. And getting on Effexor, she hasn't relapsed on benzodiazepines, I think, in 9 months.
We have a little bit of a problem here in that one of our providers locally prescribes a lot of benzos. So we get a lot of patients in IOP, and we even come to co-clinic and want to continue on their benzos, or have been on Suboxone and benzos before and want to continue them. And I'm sorry, that's not an option. So that has come about. We had one guy who came in who initially was, oh yeah, I'm going to stop taking my benzos. And then, that lasted like 3 days. And then it was, I need them. I have to have them. You have to prescribe me Suboxone while I take them. And we said, this is our policy. We can't continue to prescribe you Suboxone while you're taking prescribed benzodiazepines. And he just decided to leave.
Yeah. Ryan, we had a similar one like that. If the patient's making progress and trying to make a change, or they have small lapses, I think that's different. But if you have somebody who continues to see, continues to use it, just like the last person described, I think it's really, they need a higher level of care. They have a benzo addiction as well. You obviously need to treat their anxiety, whatever underlying psychiatric or mood disorders there. But I don't think we can help them if they continue to use benzos, because that's really a higher level of care. And so we've offered them, inpatient, but withdrawal from benzos, because these people, if they're really using it, they're going to go through a significant withdrawal, and that's kind of almost a medical management issue. Now, some of them won't. And I've had them where we've just said, I can't give you 2 drugs. If you have that much of an addiction to a benzodiazepine, as opposed to, not saying that it's perfectly okay, the recreational use that people do occasionally, the risk of overdosing. And this guy did overdose a couple times. And even with that, he wasn't willing to come off of it. And he said, we said, you need a higher level of care. I cannot take care of you anymore. So I don't think it's just the benzos. Is it a benzodiazepine use disorder? And so that's what I think makes me more nervous, because occasionally it will pop up, but that's kind of how I've been able to address it. And they are, I know, a little scary when they're at that level.
Olivia, was there something you wanted to say as well?
No, I was just going to say, like, I think that they're talking about the same patient because the particular patient was in and out of like our higher level of care programs and everything for just quite a long time and is now doing fairly well.
Marianne, I noticed you were trying to speak, but I believe you're muted.
I have just a question I'd like to propose to the group. Actually came up today. I have a patient who she travels from New Martinsville to come to clinic here. And initially both her and her husband were coming in. Her husband was a group. I was seeing her individually because we only have one group currently and they can't be in the same group together. She was doing quite well. He was not. He struggled. The issue is I've continued to see her individually. He actually got referred to Chestnut Ridge, to intensive co, was dismissed from there. They're still together. She sees me. I've had some really conflicting urine drug screen results in that one of them came back looking like simulated compliance with Suboxone. Talked to her about it. She was adamant that, no, I'm, absolutely not. And our observed urines are not as observed as they could be. Let me put it that way. They are observed, but more like the door's open and somebody's there. Anyway, the next time I screened her, she was fine and she's been doing well and things have been good. And then I tested her recently and this time her urine drug screen came back just with buprenorphine and the levels were very low and there was no naloxone. She tells me, she saw me today and said that she did admit to taking half of a Subutex, but that's all she would tell me. She said she had been taking her Suboxone every single day, hadn't missed any. And her husband has been using heroin daily and wants to get back into our clinic. And I gave her the opportunity. I talked to her a lot about, are you all of her, she's negative for every other substance. She states that she's not giving it to him or I'm just kind of at a loss because she otherwise, she shows up for all her appointments. She seems motivated. I'm just kind of struggling with what to do here. That's all.
Miriam, what are the options that you see before you?
Well, what I did today, she was seeing me. She had reportedly had almost 6 months of sobriety. Today, when I saw her, is when I had gotten the test results back from her last visit and talked to her about them. And then that's when she admitted to, oh, I did take some Subutex. But what I told her today was I gave her enough to last till Thursday. And I told her I wanted to see her back individually Thursday. And we sent out her urine again. And we sent out her urine today and sent it for bup levels. And she was very adamant that she'd been taking it every day. I said, well, we'll know today if that's true or not. But I want to see you back individually on Thursday. We have also her husband, it's been over 30 days since he's been out of the program. I agreed to see him for an intake on Thursday as well. And he would go back into co-clinic. So kind of at a standstill, but I feel like they're trying, but so that's part of the reason why I'm like, I don't want to just dismiss her for possible diversion when I think that they're really trying to get better.
Yeah, I would err on the side of doing what you're doing. I would keep them in as long as they're trying and monitor and put the appropriate guardrails in place and let time sort of take its course and provide that support. I think your instinct is what I would do.
Yeah, I think Dr. Bear, that's what we've done with people that are really heavy in recovery as couples. And sometimes it just takes a while. And so we have set, if 4 weeks to kind of make some progress, because I think that's reasonable. Because otherwise I find I end up down in a rabbit hole. 4 weeks turns into 8 weeks, turns into 12 weeks. And so it is helpful to say, you know, we're gonna give you this much time, otherwise you need a higher level of care. That's been helpful to us. But I do think testing them more often, because I've had somebody who, we saw her get a rash with Suboxone, put her on Subutex, and it took us a few months because her test kept coming back normal and it came back, buprenorphine and norbuprenorphine and naloxone and buprenorphine. And then I go, wait, there's not supposed to be any naloxone in there. So she was selling her Subutex, buying Suboxone. And it took a few tests before we caught. So just, when you've got a lot of it, it's hard to, so there is diversion out there, because people, we are part of that, but I'm less worried about this diversion about the oxy, but it does happen. So I think testing them more often, and even if, they lie once, but then they make progress, I think I would keep giving them a chance as long as you're moving forward.
Thanks. Appreciate the feedback.
So I don't know, it doesn't sound good, but what I have heard many times from patients, they take Suboxone off street, try to get off illegal drugs, right? I mean, we know Suboxone off street is illegal, we know that, but they try to get off heroin or something else. So in that sense, I think, for people take off-street Suboxone is safer. We're also doing harm reduction. I guess this is ridiculous. I don't want to, I don't want to say any positive things about diversion, but we have to think about the Suboxone itself. As a film we prescribe, it's much safer than heroin itself. We know that, right? Than for agonists. So that's one thing. But I want to discuss the topic. I have a patient who had a hysterectomy recently and has been in my clinic for a long time. And she has more than like 9 years. So had severe pain before the surgery, after surgery. So I prescribed additional films to help her with pain. But of course, Medicaid doesn't pay for it, right? So it's Medicaid doesn't pay for PRN Suboxone if it's used for pain control, because of course Suboxone is not FDA indicated for pain as Suboxone film. So my question is it fair for patients who have substance use, opioid use disorder, has been on this Suboxone for a while and then has tolerance to, but by the way, you cannot use any other pain pills. So not to get this or pay out of pocket for just PRN as needed right before and post surgery, like just for a few days. So that I don't think it's fair. I think Medicaid has to change the policy, but I don't know everybody else's view, on this.
So when Hong, the literature is changing about Suboxone or buprenorphine and pain, and I think we're moving toward maybe a more liberal understanding about the medical use of Suboxone, including analgesia. There's a literature developing, so it's just moving in.
Remember, Jeremy. Remember the article with manuscript that we published that we got from a reviewers, comments. Basically, they said Suboxone, yes, comparing with Suboxone film tablets, comparing with methadone, it has very good evidence for pain control.
Yeah.
The reviewers forced me to add it. So I just want to.
Dr. Zhang, I've been doing that for a while, and some patients will pay for it, particularly for post-C-section. So our post-C-section patients, I give them the option, and we offer them, and they'll pay for it. And it's surprisingly, because they do have to pay for it, it's only 2 to 3 days. And even some of the places have done studies, like University of Michigan did a survey of how much pain medicine people were using post-op, and they have guidelines, and it's actually only 2 to 3 days for, appendectomies, hysterectomies, et cetera. And so I agree with you. I think it would be very nice if a patient's had surgery that they would approve, so many buprenorphine pills or whatever, because we've done that in the hospital. The other thing that has happened, and again, we're going off a little on, if they get admitted, they don't, I prescribe them buprenorphine tablets in the hospital, or they get them in the hospital. They have a couple of extra strips that then they can use for that. You know, and so, you know, if they're in the hospital for 3 days, then that helps. You know, they have 3 days of scripts that gets them through their pain, but it has been very effective. I just had a patient that was up at Ruby who medical complication. She had a septic hip, and the surgeon was very reluctant. A year ago, somebody told her, you're going to need a lot of oxycodone to get better because you have on Suboxone. She waited a year. We talked about it. We went through kind of pain, you know, thinking through her pain management, what she would need, what it would mean. And she went up there. I phone consulted with the orthopedic surgeon. We came up with a plan, and she came home and has done fantastically well on, you know, they ended up giving her 2 days of OxyContin, which I don't think helped her at all. She was probably off everything, but we put her, she didn't need much else besides ibuprofen. And it was, you know, kind of the preparing for the surgery. So I think it's that psychological aspect of pain management. But I think collaborating with our surgeons in that way, they're actually pretty appreciative because they feel desperate with that, you know. And so she even went home with a PICC line for 6 weeks of antibiotics, which a year ago nobody would have trusted her to go home with that, but she had 18 months of recovery at that point. And so so for our pregnant patients, we've actually I think Dr. Marshalek's the one who kind of started me on it. It's 2 milligrams of buprenorphine every 6 hours on top of what they need inpatient. So all our residents do that. They get Duramorph in their epidural. Since it's intrathecal, it doesn't interact. And then ibuprofen and Tylenol, and they go home in 3 days post, and they most of them go home on ibuprofen. So, but I tell them very often, your 16 milligrams of Suboxone is really going to help your pain. And you say it over and over again. And whether it does or not, I think it does, but also the positive, you know, reinforcement of that, I think is, yeah. So I think petitioning Medicaid would be helpful because they do change. I think they follow WVU now. Medicaid will not approve Subutex for pregnant women anymore as of January. They're only approving Suboxone, which is a huge change.
What also frustrates me, actually, Marcus here probably can make a comment. So basically, the pharmacist told me, okay, first, Suboxone film is way more expensive than Subutex itself. And when patient has to pay out of pocket, then of course you want to choose the cheapest formulation. That's one thing. Second is like, if I give the patient, I learned this like just a couple of weeks ago. So if you give a patient the 2 prescriptions same day, same time, one is PRN for pain control, actually that patient, even paying out of pocket, is not allowed to fill the second prescription the same day. Then she has to go back to the pharmacist, because that's the pharmacist that told the patient it's illegal to fill the 2 same medicine, controlled substance, from 2 different scripts. So I talked to the pharmacist. She's very nice, but she explained to me that's something I'm not sure. So Mark, you probably can explain to us.
I'd scratch my hair on that, but I don't have much left. My people, and I mean my pharmacy profession. Oh, there's like 3 laws we need to know, and we make up the rest. Everything you just encountered there is completely false. If somebody came in with 4 scripts, it is not illegal to fill them as long as somebody in my profession checks that it's in your scope and the diagnosis, which is pretty clear. So yeah, that's just I think sometimes at the pain clinic, our team just likes me to talk with the people in my profession because it's like one-on-one, peer-to-peer. We know how that goes, and it's like, where are we pulling this from? So hopefully that makes you feel better. Now, tad bit trickier, and let's amp this up like 20 levels. From the first question or two you had in there of the, I think I was hearing the Suboxone versus Subutex, and perhaps non-medical use, let's call it abuse, potentiality and whatnot. So the whole naloxone thing in being combined to buprenorphine, you could actually check the package insert, and the package insert for generic and brand Suboxone, and all the same will tell you that people can abuse it, IV. And what that comes down to is many things, but one of them being the the magnetism, the mu receptor. Oh gosh, I said magnetism, and now I lost the real word.
Affinity.
Affinity. Thank you. Good golly, good thing my neighbor's here. The mu receptor affinity is through the roof for buprenorphine. You know, fentanyl and his buddies on the street are the only things that really come close to that. So, in pharmacologically speaking, it doesn't really work out too well. I've had that conversation on the other side of the coin. Criminal justice, DOJ, DEA, and after long conversations, they get it, and I think they just trust the drug guy. But in the end, it still doesn't matter because it's not the street trend right now, which is very concerning. It's like, you know, the street chemists and us healthcare folks and then the law enforcement side all need to get together at a table and just say, what's the deal already? That's a tricky situation. Because Suboxone, Subutex, abuse, yet pricing at the pharmacy or pricing anywhere, just happens to be dispensed obviously at the pharmacy, is completely different. Suboxone and generics even are through the roof compared to Subutex. So here we are as healthcare clinicians trying to help our patients, and they're many times strapped for cash, yet having to use something that we pharmacologically know is probably not going to get it done to prevent the abuse. Yet we have to do that because that's what the street trends are. So it's almost like we need the street trends to change so that we can all get on the same accord there. Hopefully some of that makes sense. Did I miss anything? Or who's got something to add?
Yeah, Mark, it would be great if we could work with your colleagues in pharmacy. And our colleagues in medicine too, because it's not one-sided. We have one CVS who gives our patients a lot of trouble. We have one CVS that has reported me to the Board of Medicine, and I had to defend myself. We had one CVS, actually it's the same CVS, let me just stop. But they will only take so many patients that have Suboxone. And I understand they're a lot of work and, they're weekly scripts and all that. And pharmacists are overwhelmed filling, I don't know if it's 100 scripts an hour or something obscene like that. So there's some reason, but there is a lot of stigma there too, how people get treated.
Yeah,
and so
it's
our patients pick certain pharmacies where they get treated better. But I didn't even think about the cost of this. And that cost is being borne by all of us because I would suspect most of your patients and everybody else's patients are like mine, they're Medicaid. So Medicaid's paying a higher percentage, a higher price for all of that. So it's not just, the patients, it is Medicaid.
So I'm just going to assume that you checked my CV or resume and know that I worked for that company, 3 letters you mentioned, for 10 years. So lots of experience there.
Yeah.
And yes, folks, and I was speaking facetiously earlier. That's certainly not the majority of pharmacists, but every profession has those folks that I get to talk to. It happens. It is, one thing you did mention was the limits per pharmacy, and I think that is an incredibly important thing to bring up. In fact, I actually invited the DEA and the White House and a bunch of other folks via LinkedIn to my podcast to discuss it because I'm tired of dealing with leaders and not like the guy or gal in charge. Pharmacy limits. It's not a limit. It's not necessarily based on lots of observation that a pharmacy or a pharmacist is going to say, oh, I only do 30, 100, whatever it is, like we see with prescribing. And all the CARA 3.0 coming and all these changes with X-Waiver and all that. What it actually is a wholesale distributor limitation. So when there's some pharmacists right here in Morgantown even that would love to help more patients, but are indirectly not allowed to. So when, unless I didn't say if, when we increase prescribing, where are they going to get it? And then going back to that topic I mentioned earlier of talking with other interprofessional outside of healthcare folks, one of the things that's always of concern is geographical distance to a pharmacy and a prescriber. It always, as it should, but you got to be in reality too. So think about our people in West Virginia going to Pennsylvania to get a buprenorphine of any type script, or Ohio, or Maryland, or whatever, and vice versa. Will that increase when prescribing goes up, yet there's not thresholds from wholesale distributor and DEA allowed to increase if that's what happens, because there's no push for that to happen. And it's something that it's so fundamental. And I like bringing up in a very positive manner of like, if we're going to increase stuff, like you got to look at the whole supply chain. I don't know if that provokes more thoughts. Hopefully some action for consideration too.
Do other people have like Wednesday where there's always a shortage and they're getting panic calls from our patients? Because I do. Certain day, it doesn't happen as much because I think now they've upped their whatever wholesale limits, but certain pharmacies on Thursdays are out and patients are scrambling for that. I don't know if there's a solution to that or not.
I don't know if anybody else has issues with that. The usual thing with that would be a locality. If there's clinics, having more patients on one, it flows downstream. So if there's more on the diagnosis prescribing side, then it's going to come to the pharmacy then too. I hate the cop-out answers of it's going to be case to case, but kind of fits for that one.
And I sort of saw in the chat here too, there's great conversation going on over there. Sarah Samson, I don't know if you wanted to expand on that situation you chatted in about. It could be sort of related to this topic about the Suboxone.
We had a patient that was hospitalized in the ICU here in Somersville, and she had ran out of her Suboxone. She was due for her next prescription, and we had to find a way to get it up to her because the hospital said that they didn't carry the Suboxone. So luckily we were able to do that. One of the nurses took it up and carried it into the ICU for her.
Have you talked to your pharmacy about getting it on formulary? Because we were able to. And we got just buprenorphine because you don't need Subutex in the hospital. It's dirt cheap. And since you're you're not dispensing it, but it's being given them to it directly. It took some paperwork, but our pharmacist was agreeable, and we had, and we're at a pretty small hospital.
I could call. I haven't called the pharmacy. We're not really affiliated with the hospital. But that is a conversation.
Or your inpatient doctors, because they're going to be faced, whoever the inpatient team is, they're faced with that. And so it'll help them.
That's a good idea. I didn't think about calling the pharmacy.
And Tony, I noticed you had unmuted too. Did you want to add to that?
Yeah, that's what I was going to ask. Was that an internal pharmacy issue with the hospital? Like their P&T committee decided not to carry it on formulary? And I would be shocked that they don't see some patients that need that sometimes.
Well, and I was surprised because it's a WU bought them. So I'm surprised that they, I guess they can kind of keep some of their old standards, but
that may be an in for you or the patients, because as they buy up these hospitals, they all operate independently. Have different biases. We all are. But if for example, they've bought a fair amount of critical access hospitals, and we're a 25-bed critical access hospital, so I'd be willing to help with that. If it's WVU with Dr. Barry, they've helped us, to kind of say this is what they're doing. And so I think it's getting them in the fold. I think it's good for the patients.
I'll talk with our pharmacists and see if they know who is kind of running that pharmacy.
Thank you, Sarah. And we have about a minute. Oh, I guess it actually is 5 p.m. now. Dr. Houston, I saw you hit that space bar. I didn't know if you wanted to make that final comment before we have to end the session here.
The formulary thing, talking to them directly, because I've heard it. I mean, what I've heard basically is they choose not to. And to me, it's like, can you imagine if a hospital didn't carry oxygen or aspirin? And we have to really look at it fundamentally like that. If you're not willing to treat addiction, then, we should steer our patients away from it, or we should call them out for it. And especially if it's a WVU kind of affiliated one, there's no excuse for it. So every hospital should have BUP, every ED should have access to BUP. BUP should be at every single place, just like aspirin and oxygen. So look at it. Amen.
Well, thank you all so very much. This has been such a wonderful session, and it always is, but I really enjoyed listening to this discussion. And I learned so much from you all. I'm not a clinician, but you all are so inspiring to me. Thank you so much, Jen, for that awesome case and sparking this wonderful discussion. We truly appreciate you, and we encourage you all to continue submitting cases. If you need help with submitting them, just feel free to reach out to myself or Elizabeth. So the only announcement that I have is our next session will be on May 24th, and Tony Dicchiacchio will be discussing changing harm reduction in West Virginia and implications on treatment. So keep an eye out for that reminder, and we will see you all next time. Thank you.
Thank you.